recording. Again, welcome to the NCSBY Journal Club. We are excited today to have Dr. Michael Caldwell presenting on some of his most current research. In terms of housekeeping, an acknowledgement again that this is ultimately funded through the Office of Juvenile Justice and Delinquency Prevention and through the National Center on Sexual Behavior Review. For those calling in by phone, please mute your phone to reduce background noise or other audio issues that sometimes arise. So use the mute button on your phone, or you can mute through the website. If you're joining us through the website, there is a microphone icon to the far right of the screen next to your name that you can click on to mute and unmute. At any time that you want to ask a question or speak, we'll ask Dr. Caldwell to let us know the best way to manage that. On WebEx, if you're calling in, again, through the website, there is an end-raise function that you can use. We are scheduled to go to the hour, and so are looking forward, hopefully, to some time for questions toward the end. If there's any other significant housekeeping business, so with that, I'll switch to introducing our speaker for today. Caldwell is a psychologist, faculty member at the University of Wisconsin-Madison. Interestingly enough, Dr. Solowski, who is not going to be on the Journal Club today, is in Wisconsin presenting, so they are kind of... Dr. Caldwell is known for his work with adolescents with illegal sexual behaviors, in particular sex offender registration and notification applied to juveniles. He is an expert on juvenile delinquency, treatment of violent juvenile offenders, callous and unemotional or psychopathic personality traits in adolescents. He is a regular speaker at the Association of the Treatment of Sexual Abusers and serves on the NCSBY expert panel to feedback on materials for the website and the session. With that said, I'd like to welcome Dr. Caldwell to the call and pass it over to you. Doctor, are you still there?
Oh, thank you very much. I'm happy to be here. I'm here. Things are breaking up every now and then, so I don't know if I'm coming through. Okay. Well, we'll just plunge ahead. I have myself 90 minutes to kind of polish this down, and I spent almost that entire 90 minutes trying to get my internet to run. So the slides may be a little off. I'd like to present, but and we're going to. Okay, there it is. Okay, my computer's a little sluggish. Some of this may be I may be sort of preaching to the choir, but the study I did it actually over several years. To try to establish what the general base rate is for children who are adjudicated for a sexual offense. And in particular, I was interested in trying to get an idea of the general base rate that would be useful for policymakers. So I was looking more at trying to capture large samples of kids that were unscreened and that kind of thing. Reasons why base rate's important, including those policy issues, but also it really does define how difficult it is to accurately predict kids are going to commit further offenses as they get older. Of course, I think probably most people are aware that children are overrepresented in the arrest statistics for and the offense statistics for sexual behavior. I work in a maximum security setting that's where I'm mandated to call them juvenile sex offenders, and I'm working hard not to do that anymore, but I probably will slip every now and then. Interesting things that's been happening in the last couple of decades is that crime in general, and especially violent crime, has been dropping fairly dramatically since the 1990s. And there's a lot of speculation about why that is. But really across populations and jurisdictions have been dropping. It doesn't really matter where you live. It's been dropping off. It included sexual offenses and a variety of kinds of offenses. And for that matter, including some property victimization. And as far as specifically arrest rates for rape, we see a fairly dramatic decline in the statistics for forcible rape. But that's not the only place you see it. I won't go into a lot of detail here. I'll have some in the explanation, but across the board, we've been seeing this decline in rates. There's I'll just give you a quick illustration of why this is to risk prediction, why the base rate is relevant to risk prediction. Most use the receiver-operator characteristics analysis to determine predictive accuracy of a measure. If you're dealing with a very low base rate and you construct an experiment to study the accuracy of an instrument, of course, you should put most of the people in your sample should score as low risk. And that presents a problem. And I'm going to just give you a quick illustration. Imagine we have 1,000 people, and we create a scale that has 5 risk levels, and the sample has a base rate of 10%. This is data I've just constructed just for this illustration. You get a receiver-operator characteristic AUC of 0.7, really fairly good for the world, and all look good. When you look at the table of how those folks break out, you can see that the people in the low risk category have about a 4% recidivism rate, and the 10 times higher. So that all looks good, and the chi-score looks good, and all of it looks good until you look at where I put the recidivists, and you can see that the recidivists just random distributed across the scale. There's no systematic relationship between the risk scale and recidivism. This is really the dilemma that we run into, because if you construct this way that makes sense, where most of the people are in the low risk, your accuracy will be carried by a very high negative rate. In other words, you will accurately eye the kids who won't respond. And that can be strong that if the base is low, it can be so strong that it really doesn't even matter if the has any systematic relationship to recidivism. And so that's a dilemma we all face in trying to construct these instruments. And I don't have an answer for how to solve that. But it does illustrate, I think, many people think that the ROC is useful because it is not affected by the base rate. And I want to just make that point, but that's actually not entirely true. So the other thing about the drop in violent and especially sexual violence is that the vast majority of people who are arrested for sexual offenses are first offenders. So racism, of course, would tap into those individuals who were not affected by whatever forces caused the overall rate to drop, because most of the drop is going to be first offenders. That left open the question, well, is recidivism dropping among that have been caught and adjudicated in small? The answer, at least coming from Minnesota Department of Corrections, is yes. They've seen about an 80+% drop in reconviction rates for their adult men who are sexual offenders, 85% actually. And we've seen it also in Wisconsin, a drop to about 72%, I believe it is. The Wisconsin data is interesting because we've actually seen about the same raw number of recidivists in each of those timeframes. It's just that we're releasing larger and larger populations, and so the rate of recidivism is declining, even though the raw number of individuals who reoffend each year has been about the same. So it could be that we're just simply locking up a lot of low-risk individuals, and that accounts for that data in Wisconsin. To study to see if that drop in recidivism is also true among adolescents and children. It took several years. If you ever think you want to do a large meta-analysis, because you read an awful lot of studies that have nothing to do with or that are not usable, and you also have to do a lot of studies that are usable. Large search, I was interested in specifically in policy relevant information, and so I wanted sample sizes that were reasonably large. I made a cutoff at 20. Since most of these, it was very rare to find a study of female sex offenders, so I didn't that I could. I looked for samples that were not fully screened, so samples of all kids who were found not guilty by reason of insanity, or a couple of studies just of treatment successes. Those kinds of things were screened out, and I had to report on some basic information. Essentially, that yielded 106 data sets in 98 reports. Some of these were state reports, their overall data, and they might include data sets in one report. That's how that worked out. Published between 1938 and 2015, going back quite a ways, just short of 34,000 individuals. And from different countries, but heavily weighted towards the United States, and about a 5-year follow-up time. Now, as you can do one of these studies, one is the easy way, which is what I do, and that is you go back to, say, 2000, and you find all the kids who were in the Department of Corrections for a sex offense, and you identify those as your sex offenders. And as adult arrest data is public domain, it's easy to collect follow-up data for those guys, and so that's one way to do it, is a retrospective study, and we have 7 that were done that way. The other way is to get to a juvenile court and catch the kids who they first come in on their adjudication, and normally those only are able to follow the kid through his experience in juvenile court, juvenile custody, and then once he leaves, they usually don't follow them up. There are a few that did both, juvenile and adult, but not too many. And others that did retrospective studies that did collect both, and we had about 51 of those. A number were peer-reviewed. Of course, you always want to have a good selection of non-peer-reviewed or unpublished data, because we always have data in our desk drawers that we don't use because we've not published, because they'll find things. Looked at the setting that the kids were in, that the study was conducted in, whether it was a community, high security, or setting. The overall weighted mean sexual recidivism rate was just under 5%. Recidivism rate about 40%. These are pretty numbers, not too surprising. Average follow-up was, again, just over a weighted mean follow-up, rather, of just 5 years. But the mean is a little misleading because 49 of the studies reported sexual recidivism rates below 5%, and 3 reported recidivism rates at 15% or higher. I think actually about 9 studies that were, or 7 studies that were at 1% or lower. So the middle 75 percentile range was 3 to 9%, or 3.5%. And it's a very busy table. I won't waste time going through a lot of this, but I do want to point out just that I'm finding that juvenile, only these 28 studies that studied just juvenile recidivism, about a 7% recidivism rate. That's unweighted. But they only followed them for a little less than 3 years, and that makes sense because age is 15, and so they job in about 3 years. The adult recidivism studies about the same recidivism rate, but a much, much longer follow-up time, even though the age that they first was the same. So what we find when we look at studies that captured both data, fairly dramatic drop-off in recidivism rates from the time the child is an adolescent until they get to the adult system. And most of those studies, in fact, I think all of what I looked at, the two reoffended as adolescents did not reoffend as adults. So the adult recidivists tended to be a different population. Significant differences in the setting that the kid was drawn from, and that actually makes sense because a lot of the community settings, kids would eventually end up in secure setting, and so those aren't really clean categories. One of the things I was interested in was this issue of unpublished studies, the broad samples. 9 of the 10 statewide or national studies were unpublished. They had a little bit shorter follow-up time of just over 3 years, but also reported significantly lower recidivism rates. So we tend to see kids getting into treatment programs or secure settings who really are in a bit more trouble or are going to have more behavior problems than the overall population. We see some of these policies that are based on recidivism rates. Be careful about applying a broad policy to all kids on the basis of recidivism rates you're seeing from treatment programs, which are actually capturing more kids with more problems. One of the questions I wanted to look at was follow-up time. How long do you have to follow a population before you basically got sure that you're going to get? I won't walk through all of this, but essentially through a couple of different analyses, I found that follow times of 30 months or more reported about the same recidivism rates as that were up to 36 months. So, in other words, we know that the longer the follow-up time is, the more recidivism you'll discover. With juveniles, that seems to top out at about 36 months. As you go past 36 months, capture a significantly larger number of recidivists. That makes some sense because adolescents they're not patient. They tend to be impulsive, and if they do reoffend, they reoffend fairly quickly. And so studies of 5 years, I had a few studies that went out 20 years or 35 years, could have kept it to probably 3 to 5 years and been okay. So I wanted to quantify exactly how much of a drop have we actually seen, if we've seen a drop. And so one of the problems there is that studies that went before 1980, often their population was made up of large samples of people who were adjudicated for homosexuality or cohabitation. When you get back into the 30s, some of those samples are largely adolescent females who are charged with promiscuity. And so I had to clean those off. So we did studies done before 1980 because of all that. And that was with a total of about 94 studies to look at. I have 2 groups, and 15-year sample of the most recent 15 years, and the oldest 15 years that I had, which went back to into the 90s. So this is the result of the regression analysis. The step we put on in the 12 months. This was to predict the recidivism rate of the study. And the follow-up months accounted for about 12% of the variance. The surprise to me, at least, was the year that the follow-up was conducted accounted for just slightly more of the variance than the amount of time, the length of the follow-up. So we had a very significant drop in recidivism rates as we got more recent studies. In fact, I'll just go ahead and punchline here. It looks like it's about a 73% drop when you look at these 2 categories. From old studies, about 10%, more recent studies in the last 15 years, just under 3%. So a substantial decline. And decline actually that's pretty much in line with what we're seeing from data from Minnesota, Wisconsin. There's also some from Florida, all in roughly that 65 to 85% range. The rate of recidivism for these samples, though, was not significantly, had not dropped significantly. The decline that we do see here in most of these studies, they included recidivism in general recidivism, and that 4.5% drop probably is heavily affected by the drop in sexual recidivism. Let me skip over this. I did want to mention, though, that since we've seen this drop and actually are not totally sure why it's happened, it is the case, and this is data from Utah. It's the case that we have these kinds of fluctuations periodically. It does not mean that rate is going to continue to go down or that it's going to stay low. We've seen that with homicide rates in some cities like Milwaukee, where above here in the last couple of years. So I was going to understand why it's dropped. We really have much of a handle on why it wouldn't go back up. And that leads us to looking at that question. One of the observations I got from reviewers was that maybe there are fewer being reported to the police and those kinds of things. Actually, I'll show you some of this. If you look at the cases known to professionals, these are physicians or school counselors or mandated reporters. You see that they also have had a drop in the cases they're seeing that they are referring to protective services. If you look at protective services, this is kind of interesting. The number of victims that they're working with has been also declining, but the number of recipients of their services has actually been going up. They're staying busy. And I think the reason for that is that Child Protective Services, at least all of the ones that I ever worked with back in the 90s, were horribly underfunded. As they've got a little bit of breathing room with involved in maltreatment cases, unable to work more with families and expand, do some of the things that they, I think, wish they could have done back in the 90s. But in any case, we are seeing some decline there. And these are, this is the graph of associated sexual abuse cases from Child Protective Services agencies, and about a 62% drop from the 1990s to 2010. And it's actually doesn't follow quite, doesn't necessarily on the physical abuse rate drop, but has dropped also. So one possibility is that somehow all of these, that somehow people are just less likely to report. So the way to tap that is to look at victimization survey. And in the crime victimization survey, you don't see an exact match of the curve. There's a 69% decline. The overall rates look about the same as rates and so on. And that's true for actually all kinds of crime besides sexual crimes. So the rule out. It doesn't look like it looks like this is an actual genuine drop in sexual violence in society. It's not that fewer people are reporting it. It's that Child Protective Service workers are referring less cases to the police. It's not that the police are any less aggressive in pursuing these cases, as far as we can tell. So there are other explanations I've heard out there, and I think I've touched these too. One is, though, that possibly sex offender registries and community notification, maybe they have suppressed offending. Maybe they've actually worked. If you are familiar with the research in this area, it's amazingly consistent that I don't think I've seen more than or two studies that have found any evidence that sex offender registries lower the rate of either first-time sexual offending or sexual recidivism. So there's no evidence to really support that, and quite a bit of evidence to contradict that possibility. Reviewer said that possibly more kids are going into secured custody, so they're incapacitated, and another reviewer said possibly fewer kids are going into secured custody, so there's less of a iatrogenic effect on that. There are actually fewer kids going into secured custody, and so that's a possibility. But there isn't much evidence to support that, and it doesn't really explain why you would have a drop in among these first-time offenders, which, as I mentioned, is the majority of the samples. Wouldn't explain the victimization survey data. We're just getting better at treating antidepressants. We also do a better job. It is true that from 1990 until today, the standard for treatment and our understanding of what works in treatment and so on has improved. The evidence for treatment is not high, but there certainly are a number of studies showing very good outcomes. So there really isn't any evidence to contradict that possibility. Even though the evidence in support of this is not as strong as we'd like to see more research in this area. This is the Belgian explanation. This phenomenon has been happening in Eastern Europe or in Western Europe also. The government of Belgium listed a possible report that violent video games were accounting for a drop in violence. Essentially, their theory was that kids that are prone to be violent are at home in their mother's basement playing violent video games instead of out raping and pillaging. And so, well, I suppose, but every meta-analysis of violent video games shows that it contributes to more aggression. It's hard to believe that violent video games would somehow incapacitate kids that are prone to this. And in fact, of course, if you work in this field very long, you see a lot of kids whose sexual misconduct started when they were playing a video game with another kid. Last explanation that I wanted to address is just the effectiveness of prevention programs, and certainly there have been a lot of advances in very detailed understanding of particularly college level and high school level sexual violence. What leads, for example, to be aggressive, sexually aggressive, and how they can work on taking that apart. I was in middle school. The class on human sexuality was the priest talking about something that was so obtuse that I couldn't even follow that was supposed to be about sex. My daughter, when she was in middle school, the crisis center folks came in and did a very good, very well-informed presentation and discussion about how sexual violence actually happens, how girls could prevent them, not put themselves in situations that are dangerous inadvertently. There's now several college programs. The research has mostly been done with college kids, but both programs implemented in college that show very good results in reducing sexual violence, working with men to take apart some hypermasculinity issues and some distortions about several essentially rape myth distortions, and working with women to sort of understand, how sexual violence kind of happens. It's not the stranger who grabs you in the park; it's the friend that they party with, and that you've both been drinking too much. That's more likely to be the problem. That's all I have. We have plenty of questions, so I'll open it up to questions. Dr.
Caldwell, thank you so much for such a well-done, concise explanation that is so relevant to the work that everyone on the call does. Before I open it up to questions, just for the sake of attendance, there were two people that joined a little late. I'm wondering if you could identify yourself by name.
Hi, Sunrise from White Buffalo Cafe.
Sunrise, glad you could get it.
Yes.
This is Leilani Hinton with Dallas County Juvenile.
Hi, Dr. Hinton.
Hi.
And I thought, oh, go ahead.
Sorry, this is Seema Van Doren with the Dean Norton Child Advocacy Center in Charleston.
Well, you joined. Terrific. I've got everyone then. Thank you so much. So this is a lot of information, and like I just mentioned, it's so relevant to the work that we do, regardless if we're working with children, school-age children, or adolescents, because people often in the field want to know kids long-term. Are there concerns that a 3-year-old is going to grow up to be an adult sex offender? What about the 12-year-old that's had more significant behaviors, or the adolescent who has multiple adjudications around their sexual behavior? And this helps to provide some education to others working in the field. So I'd like to open it up. I'm going to start muting people. If I have background noise, I may mute you again. But I'd love to open this up. What questions do you have?
Well, hey, Amy, this is Kristen. Okay, so tell me what this means. This means that we'll be locking all these kids up, or that in the world, or...
Well, there's
Doctor, did you hear the question?
I think it means a couple of things. It's sort of a no-brainer, but some of the policies around.
Okay.
Can you hear me?
We can hear you now, sir.
Yeah. So, I think it has a couple of implications. One is that I establishes that the policies around registration and notification and offender civil commitment, which there are still quite a few adolescents committed to civil commitment. Those really have enormous opportunity cost. We probably are getting much more bang for our buck with prevention programming, almost certainly wasting a lot of resources in these areas. So from a public policy standpoint, it certainly pushes us towards prevention and early intervention and that kind of thing, I think. Other thing I think is that it raises a question in my mind as to whether we're ever going to be able to develop a risk assessment measure that count those few kids who are likely to reoffend sexually. We can pick kids that are going to have ongoing behavior problems and the rates for any kind of continuing behavior problem is about 40%. So that type of assessment is more doable. But we also pick out the kids who are may have better luck picking out the kids who are likely to desist from offending. But the holy grail in these efforts has been to try to identify the kid who at years old is doing the same kinds of sexually inappropriate behavior that a lot of kids do, but who's going to grow up to be Jill Turner or Jeffrey Dahmer or someone like that. That's probably just not realistic.
So, Dr.
Just to kind of finish that, I think we need to start moving towards more of a based assessment and start to try to work towards judges and various folks to lower the idea that they need a sexual recidivism risk assessment, because that's really on our thin ice when we try to do those.
Dr. Well, would it be fair to say, I'm thinking of what you said early on in response to Kristen Al's question. She's with the Dallas Children's Advocacy Center in Dallas, Texas. mentioned something about, this kind of information is important to help people understand where to best put the money to help these youth. I think that's, one, is that an accurate interpretation of what you said?
Yeah, that's accurate. I think, yeah.
I think so
Yeah,
important
that's accurate. Yeah.
For the people who are
it
working.
I think it shows that. Yeah, I think it shows that the money we're devoting to these registries and all of that, we have much stronger evidence that prevention programs will be effective and they cost a fraction of the cost.
The thing for people who are working to implement evidence-based practices in their community to help those with the money better understand that money could be much more effective.
No, and that's super helpful. We presented to a part of our board yesterday about going with this program, and universally they were, I don't use the word appalled that we would serve these kids, but that sort of a little bit what they were like, are you sure this is what we want to do? We want to let these little monsters in the building? It was very emotional and personal real fast. And so I think being able to kind of have that the research behind it, the economics behind it, there's a lot more than just this emotional reaction if we can kind of help add like more reasonable people's work into this. It's a good thing. Does that make sense?
Go, Caldwell.
I didn't get that kind of program. Well, I didn't include it, but I also got a meta-analysis. I don't know if I'll ever publish it, but comparing what you have in treatment outcomes to the commonly prescribed medications and how effective they are. And the most commonly prescribed medication that's not a psychometric or a psychotropic medication is Lipitor and statin medications to prevent heart disease and stroke and so on. And they usually have an effect size of the large meta-analyses that have been done, effect size is somewhere less than 0.20, and typically in the mid-teens. The effect sizes we're seeing from the studies that have been published on outcomes commonly report effect sizes of 0.7 above. Averages are often 0.4. So we often underplay how effective treatment can be, and especially treatment of children seems to be more effective. It seems to be much more effective than these very commonly prescribed medications that about half of the population are taken to prevent heart attacks.
What questions do people on the call have?
Well, I mean, another one, and that is just that I read this, and then I also do put the victim hat on, and I'm like, the number of victims, I'm surprised that it's really more than I'm surprised it's significantly less than it ever was, because it feels like a very, very heavy volume. Someone is perpetrating these crimes against kids, and they're doing it a lot. So I hate we can't predict who it's going to be. I mean, is that the outcome of this, is that you're saying you really can't predict who is to continue on with the recidivism rate?
Typically, yes, but the one factor that has been probably the most robust is the kid who is involved in a lot of delinquency, the kid who's got a lot of behavior problems, the kid who's most likely to continue to be sexually aggressive also. And so something, but it's also important to keep in mind that the majority of these offenses are committed by kids who were never they've been detected for the first time, and none of this, including in my mind, even with the drop in the victim survey data, we're still looking at just a horrific public health problem. If we had as many incidents of or some serious health issue as we have sexual violence at the top of the list. And it doesn't diminish in any way the seriousness of the problem and the harm done to victims. It, I think, takes us in a different direction in terms of trying to address it. The trying to put down registries or lock kids up for a long period of time. The other thing I wanted to point out is your really robust finding is that kids tend to continue sexual conduct until they get stopped. And so one of the misinterpretations that I sometimes see with this information is that we shouldn't intervene as much as we do. And I really disagree with that. I really think you need to step in and make sure that the situation gets under control, the behavior stops. If it means taking the kid into a secured setting, and that's the only way to do it, then I think that's what you should do. What you shouldn't do, though, is with a kid who's at age 14 or 15, and he's been in treatment, and now he's 18, and he's to have gotten something out of treatment. You shouldn't that he's destined to continue with this behavior.
So that's very helpful.
Question do people have? We have, say, just right at 10 minutes before the hour, and I'd really love to use that time, pick the brain of an expert. Cricket that I've identified a species of in every state of the country.
I wonder if there's a way we can scroll through some of the slides again and see if there were any specific questions on some slides.
Dr. Caldwell, you're in control of the slides. If you want to go through them, just kind of scrolling through them to see if that spurs any questions or comments that people may have.
Consider this prevention for problematic sexual behavior a type of prevention work?
I think that's an interesting question. It is, in my opinion, both prevention and response. Children are typically only referred to treatment services once concerning problematic or illegal sexual behavior has been identified. It is on families to refer their children to treatment for sexual behaviors as prevention. There are some cases in which we in Oklahoma have accepted families where there has been a level of concern about a child's age-typical sexual behavior and typically concern about parental capacity to supervise, that we have to children into the group as more prevention. Typically done that with siblings of children with problematic sexual behavior, and that should be more likely to happen in our preschool age program and for younger children in our school age program. I'd love to put this over to Julia Grimm, who's with the D. Norton Low Country Children's Center in Charleston, South Carolina. There is currently providing all three of the Oklahoma models, and get a feel from her experience on the East Coast.
Yeah, so the question was, is this kind of intervention also kind of so that I understand what the question was, this intervention is also sort of doubling as prevention work. Is that right?
Correct.
I mean, whether you view it as you're preventing future assaults from happening, or you are, we're expecting to be able to use it with victims who are having increased in standardized assessments about product sexual concerns. And so, you know, did those addressing this and giving them the tools to be able to make behaviors better, could a point be that it is a prevention effort in our facility?
I definitely would agree with that. In fact, I remember having a conversation when I first started this work. I remember having a conversation with our clinical director at the time, and I mean, I was brand new to this population as kids, and was just reflecting on what it's like to work with youth who have acted out sexually in an inappropriate way as compared to being a forensic interviewer and being a therapist of victims for, you know, before that. And just sort of that, you know, to vulnerable, but just to acknowledge that sort of conflict that comes up when we work both the victims and with youth sometimes. I remember having a conversation with him and just sort of reflecting on that conflict, and what said is exactly what you're getting at, is that by working with these youth, these adolescents, as well as these school-age kids and preschool kids, where sometimes, not always, but sometimes their behavior is sexually reactive to some things that they've experienced, or comes from, you know, having exposure to a very chaotic, sometimes dysfunctional household where there are other typologies of abuse or neglect or poor supervision. By treating the inappropriate sexual behavior, we are intervening at a place where I think we have a lot of power to prevent future instances of abuse, and not just sexual abuse, also physical abuse, exposure to substance abuse. I mean, just for the etiology of these behaviors and how they don't exist in a vacuum, and how, while there's no quote-unquote profile for these kids, that we do know that some of the risk factors are chaotic, disorganized family households, and by being able to do this work in that sort of family way, I absolutely see it as both intervention and prevention, especially in a child advocacy center setting.
Cool. Good. Thank you very much for that. Glad you're on.
Yeah, absolutely.
Julia and her partner in crime, Carrie Jenkins, little resources. We are always happy to have them on. And thank you so much. That was a terrific response.
Absolutely. Happy that I could share that little bit that we've learned over the years.
Dr. Well, thank you so much. You've put your slides up, and I see that you have been kind of scrolling up and down to expose all of us to the slides at a quick glance. We have just a few minutes left, and I make sure that if anyone has a burning question or comment, that you have a quick second to be able to out. No one has that burning feeling. That's probably good. There's medication for that if you do, however.
Oh my gosh, Jimmy.
I'm glad it could be recorded for prosperity.
Exactly.
Dr. Caldwell, thank you again so much. I should have acknowledged at the beginning, for those that didn't quite catch, Dr. Caldwell was having some significant technology problems, and he is actually doing this presentation today from a local library where he was able to find space and an internet connection. dedication at the highest. Yes, I appreciate you, Dr. Caldwell, being on the call and sharing your knowledge and expertise with us. I appreciate everyone that attended the call today. We had teams here from Chicago, Charleston, South Carolina, Dallas, Tulsa, Alabama, representatives from NCSBY from across the country, Chris Brace through right hand, our NCSBY team members here in Oklahoma City, also in Little Rock, Arkansas, and Sunrise from the Rosebud Sioux Tribe in South Dakota, Associated Range. Thank you all so much for being here today. If you need anything now or in the future from us as training or technical assistance, don't hesitate to reach out to any of us. You can do by email at ou-ncsby.ouhsd.org. With that, I will go ahead and stop recording. And then a great thank you to Dr. Caldwell.